And now it is my pleasure to introduce today's speaker, Dr. Zakaria Hakma. Dr. Hakma is an assistant professor at the Department of Neurosurgery at Drexel University College of Medicine. He is a dually trained cerebrovascular neurosurgeon who received his medical degree from Damascus University in 2001. He completed his neurology residency followed by neurosurgery residency at Temple University, and then a cerebrovascular fellowship at the Neuroscience Institute with Dr. Vez. After fellowship, Dr. Hakma joined Global Neurosciences Institute. He is currently serving as neurosurgery section chief at Robert Wood Johnson in Hamilton. He has special interest in cerebrovascular diseases, including carotid revascularization. He published multiple book chapters and peer-reviewed articles in this area. Dr. Hakma provides endovascular interventional procedures, as well as open cerebrovascular and skull-based neurosurgery to a wide spectrum of patients with complex cranial disorders, including acute strokes, aneurysms, arteriovenous malformations and fistulas, cavernomas, extracranial and intracranial occlusive vascular disease. Today, Dr. Hakma will review carotid artery stenosis and current state of its treatment options. Dr. Hakma.
Hello, good morning, everyone.
Good morning.
Share my screen. Can you see my screen here?
Yes, we can.
Great. All right, good morning, everyone. I'll talk to you today about carotid artery stenosis, and we want to review where do we stand in 2021 in terms of treatment options and etc. Disclosure, no relevant disclosure related to the topic. I am biased. I love to operate. I'm a neurosurgeon. I used to be a neurologist, and I'm married to one, so I get to make fun of neurologists. Today, we will discuss history of carotid disease. We'll go over pathophysiology and histology, carotid revascularization. We will talk about carotid endarterectomy, stenting, treatment for acute carotid occlusions as well, and best medical management. So why carotid disease? Carotid disease is a main reason for having ischemic strokes. As we all know, ischemic strokes can happen from multiple etiologies. As you see on the diagram on the right side, can result from a cardioembolic disease, such as having a ventricular thrombus, valvular disease, atrial fibrillation. Also, about 20% of ischemic strokes is a result of carotid artery disease, either from having a severe stenosis that results in a low flow state, or more commonly seen is plaque rupture causing thromboembolic events. And on the top of the diagram, we see the intracranial pathology that can result in stroke, such as the coronary infarct from having ventricular striatic disease, as well as stenosis from progressive atherosclerotic disease of the intracranial vasculature. Stroke is the fifth most common cause of death in the United States these days. We see about 1 million stroke annually in the United States, and it's a very expensive problem. The risk of stroke correlate with the degree of the stenosis of the carotid, as well as the presence of a vulnerable plaques, and we will go over these features during the talk. The most common location of atherosclerotic disease is at the bifurcation. However, we see it sometimes either in a higher or lower location, and a lot of times it's more associated with either dissection or other pathology, neck radiation, etc. I promise I'll talk about some history of carotid disease. I'll take you back 2,500 years. The Greeks knew a thing or two about carotid disease, about carotid arteries. I didn't know much about carotid disease, but they knew a thing or two about carotid arteries, and they used to train their soldiers to crush their opponent's carotid to induce a state of stupefaction or sleep. And that's where the carotid artery got its name. Katatikos means stupefy, and that's the origin of the name of the carotid artery. Fast forward 2,500 years, and it took a Canadian neurologist by the name of C. Miller Fisher, and for us neurologists, he is one of the giants of neurology. And he wrote the landmark paper in 1951 that correlated the presence of these ugly lesions with the risk of having an ischemic event. And that opened up the race to see who can take out these lesions and dig out these ugly plaques from the carotid artery and put the artery back together and still end up with a live patient. And this was a race across the pond between the United States and England. And eventually Debeki, who's a giant of a surgeon, American Lebanese surgeon, a pioneer, and he was able to perform the first successful carotid endarterectomy in 1953. However, this surgery remained unpublished for 12 years, but he's credited for the first successful carotid endarterectomy. This diagram kind of describes humanity understanding of carotid disease. We knew about strokes about 400 BC. Willis described that you can survive a carotid ligation because of the presence of that circle of Willis and the intracranial anastomosis that will allow you to ligate one carotid artery and still survive it if you have a competent circle of Willis. Virchow in 1856 correlated the carotid problem with eye issues and demonstrated that you can have blindness if you injure a carotid artery. And fast forward to 1951, Miller-Fisher described correlation between strokes and carotid pathology. Debeki was able to perform the first successful carotid endarterectomy in 1953. And 1980s, we ushered the era of angioplasty and endovascular interventions. What is the primary disease that affects carotid arteries? The most common pathology that we all deal with is atherosclerosis. As you see in this histopathology slide here, one is the common carotid artery, two is the external carotid artery, and this narrow corridor is what's left of the internal carotid artery. We see in this slide, there's a very big lipid-rich core that's necrotic, and the asterisk here is a intraplaque hemorrhage. And I will go over the risk of this intraplaque hemorrhage down road in this talk, but this is a very high-risk feature when we see it on imaging studies. And the arrow here points to a very thin, fibrous, and partially ruptured cap, fibrous cap. So these three features, the necrotic lipid core, the intraplaque hemorrhage, and the thin fibrous cap are the most feared features of a carotid plaque. Other etiologies for carotid disease is trauma causing dissection, iatrogenic injury from surgery, radiation, neoplastic processes that can either compress or invade the carotid artery, and vasculitis. But for the purpose of this talk, we'll be focusing more on the 99% of the pathology, which is the atherosclerosis. To be able to manage any pathology, we need to have an understanding of its natural history. This is some data from, I circled it down here, from the 1990s, which is a little old by today's standard, and things changed since then. But at that time, the risk of a stroke in symptomatic patient ranged from 22 to 26% in 2 years in moderate to severe stenosis. In an asymptomatic patient, it was as high as 18% in 75 to 95% stenosis. So almost 20% risk stroke in 5 years in asymptomatic patient. We'll keep that in mind that this is a little bit outdated. Risk factor for carotid disease, just like my friend here, Homer Simpson, fat, smoker, hypertensive, lack of exercise. And all these modified risk factors is the goal of the CREST-2 trial, which I'll talk about extensively during this talk. In the CREST-2 trial, we're trying to attack these modifiable risk factors and these are the primary goal of the medical arm of the CREST-2, aspirin, systolic goal of blood pressure of less than 130. Every time I open a journal, look at guideline, this goal keep going lower and lower. So now the goal is less than 130 systolic. LDL now goal is less than 70, and obviously the tobacco cessation, activity, weight. And the amusing part is the risk factor is performed by a site personnel and lifestyle coaching program, which might be difficult to achieve in real life. I don't know about many patients who has lifestyle coaching. Non-modified risk factors, family history, age, blah, blah, stuff that you really can do anything about. So how do we find about carotid stenosis? It's either asymptomatic, found during workup for a brewery or screening by the primary cares. And as a cerebrovascular neurosurgeons that we deal with strokes all the time, we are encountering carotid disease more often as symptomatic pathology. And these can be TIAs, strokes, or ocular problems. Modalities to evaluate carotid disease. The first modality is carotid duplex. It's safe, quick, and non-invasive. However, it does have some limitation. It can be overestimating some lesion, also can be limited in the setting of calcification or a string sign, and obviously in patients who have no neck or high lesions, where the lesion is above the mandible, it is really hard to see these lesions. In our practice, if we see an abnormal carotid ultrasound, we would do another test to confirm the degree of the stenosis before we start tackling the problem. CT angiography is an excellent study. It provides very valuable anatomical information about the location of the lesion in relationship to the patient's mandible, how high is it, the tortuosity of the vessels for endovascular evaluation, the calcification of this lesion. Is this going to be one of these rocks that is not going to open with a balloon and better managed with an endarterectomy? So it's a very valuable study. However, it's some radiation and some contrast, so it can be limited in some patients. MRA, also a very valuable study. And the newer MRA, which I'll show you some pictures now in this talk, can provide very valuable prognostic information about the plaque morphology. And as always, cerebral angiography is the gold standard for evaluating any vessel pathology. And part of the CREST trial, just to kind of emphasize the limitation of the carotid ultrasound, they would require specific criteria to enroll patients in this trial, not to enroll a lot of patients who do not have significant pathology. And most of the time, they would require you to obtain another study in addition to carotid ultrasound, such as CTA or MRA. The way we measure carotid stenosis is called the NASIT criteria, or North American Symptomatic carotid endarterectomy trial. This is the landmark trial I'll talk about in a little bit. But the NASIT method, it essentially looks at the area of the greatest narrowing in the internal carotid artery, which is in this area is A, and compare it to the normal distal internal carotid artery, which is here C. And so we'll divide A by C, and that will give us the degree of the stenosis. It is the most commonly used method in the United States. However, it can underestimate the degree of the stenosis if the patient has very severe or flow-limiting carotid stenosis, which will make the distal internal carotid artery look smaller than what it is and can underestimate the degree of the stenosis. The other method that we can use, it's called ECST criteria, European Carotid Stenosis Trial criteria, which compare A, which is the degree of the stenosis at the internal carotid artery, to the expected caliber of the carotid bulb, which is B here. This can overestimate the degree of the stenosis, and it's not widely used in the United States. Our group looked at the carotid artery ultrasound and compared it to angiography, and it was a very interesting study where we found that 43% of patients who had carotid ultrasound showing high degree of stenosis, the management was changed based on angiography in 43%. That's not a small number. And in fact, 25% of the patients, quarter of the patients who we thought that they had treatable lesion based on ultrasound did not have any significant stenosis on the angiogram, did not require treatment. That's a huge number. In practices where surgeons operate on carotid ultrasound alone, they are operating on a lot of patients who do not need surgery. And for example, this is a recent example of a patient, a 62-year-old who presented with multiple episodes of TIAs, and a CTA showed a 80% stenosis, as seen here on the pictures from the angiogram and the patient from the CT angiogram. And the patient was scheduled to have an angioplasty and stenting the next day. This is the angiogram from the same patient. And as you see, there's literally 0% stenosis on this angiogram based on the NASIC criteria. And obviously the patient did not require any intervention. So it's very important to look at our diagnostic screening tests and be prepared to confirm it with other studies. And when in doubt, catheter angiography will give you the answer. So what are the treatment options for carotid disease? Medical treatment, which include antiplatelet medication, aspirin, Plavix, cholesterol-lowering medications such as statin, blood pressure medication, etc. Interventions is divided in three arms: carotid endarterectomy, which is the gold standard; endovascular treatment, carotid artery stenting, either transfemoral or transradial; and the new method is a hybrid treatment of both called TCAR, or transcarotid artery revascularization. This is the boring part. You cannot have a talk about carotid disease without going over some trials, so I'm sorry. It is very important to realize how many studies are done about carotid disease. Carotid artery endarterectomy and stenting is the most studied procedure in the history of medicine. This is like mind-blowing that this disease is the most studied disease in history of medicine. So far, we have over 50,000 patients enrolled in trials for carotid disease, and we are waiting for more. This is a summary of some of the trials. We started with comparing medical treatment to carotid endarterectomy in the 1980s, and we looked at NASIT and ECST, and these are the trials that established carotid endarterectomy as the standard of carotid management for symptomatic and asymptomatic patients. Again, that's in the 1980s, 1990s. And we moved on to comparing carotid endarterectomy to stenting. And we started looking at symptomatic versus asymptomatic, and also we looked at high-risk patients for carotid endarterectomy. This is kind of the cycle of the progression of carotid artery trials. In the 1980s, we looked at symptomatic patients. The question was, does endarterectomy benefit our patients who have symptomatic stenosis? And the answer was yes. So we moved on in the 1990s to answering the questions, how about endarterectomy versus medical management in asymptomatic patients? And at that time, the answer is yes, and that will take with a grain of salt as well. In the 2000s, carotid artery stenting became mainstream and widely accepted, and the trials were, how is it compared to the gold standard of surgery? And in 2010 and forward, we are looking about stenting versus in asymptomatic patients. Just to regress a little bit to carotid artery surgery, the NASIT trial, North American Symptomatic Carotid Endarterectomy trial, that's the NASIT trial, is the trial that put carotid endarterectomy on the map as the gold standard treatment for carotid stenosis. And CEAs became one of the commonly performed procedure in vascular surgery. In this trial, the risk of stroke dropped from 22% from 28% to 13% at 5 years. This was duplicated in the European Carotid Stenosis Trial, ECST, and also the risk of stroke dropped from 20% at 3 years down to 6% at 3 years. It's a huge drop. It's better than any medication or anything that you can have imagined with these results. And then they looked at ACAS, asymptomatic carotid artery stenosis trial, and there was modest improvement from 11 to 5%. And based on these trials, American Heart Association came up with the guidelines for treatment of carotid disease. And the summary of these guidelines is If the patient is symptomatic, okay, had TIAs, stroke to the ipsilateral to the carotid lesion, if it's greater than 50% stenosis and you can perform the procedure with less than 6% complication rate, that's accepted treatment. For asymptomatic patient with stenosis greater than 60% based on NASIC criteria, and you can perform these procedures with less than 3% complication rate, that's acceptable option as well. I'm not going to bore you with this slide. It's some of the trials that looked at carotid artery stenting. The one thing I want to mention in this study and this slide is the CREST study published in 2010. And as you see here, it is the biggest trial. It enrolled 2,500 patients. So when we talk about carotid artery stenting versus endarterectomy, this is the study that is most commonly quoted. It has the most amount of patients, is the best designed study of all these trials. And the summary of this trial is that it started in year 2000, ended in 2010, so it took about 10 years, enrolled 2,500 patients approximately, and looked at aggregate results of stroke, MI, and all-cause mortality during the per-procedural period. And at the end, these two procedures were pretty much equivalent. They had very close endpoint, 7.2 versus 6.8 for stenting versus endarterectomy. In the perioperative period, the surgery had a slightly high risk of MI. Stenting had a slightly high risk of having minor strokes. And at the end of 10 years, the two modalities were pretty much on par and equivalent with the end result in terms of the patient, how is the patient doing, is he alive, and is the graft or the stent patent at 10 years. So this study showed that carotid stenting is equivalent to carotid endarterectomy. So where do we stand in 2021? Do we go right? Do we go left? Do we need more trials? And unfortunately, the answer is yes, we need more trials. Why? Stroke rates are plummeting. As you see in this graph from the 1970s, 2010, there's a significant drop in stroke rates. And we figure out a way to deliver guideline-driven, comprehensive vascular medical care to these patients that lower these risk factors, diabetes, smoking, hypertension, and cholesterol medication, particularly statin, that is responsible for the significant decline in stroke rates. On the flip side of the coin, where the surgery is getting better, right? Technical expertise is better, technology is better. We're able to revascularize these patients pretty well with very low risk. We learned to protect the brain during carotid endarterectomy. We learned the value of putting a patch in small vessels to reduce the risk of restenosis. We learned the value of shunting in selected patients during the procedure, particularly if the patient was done under general anesthesia, to perfuse the brain while we're cleaning up that lesion. And we learned to do intraoperative monitoring to detect any hyperperfusion to the brain during these procedures. So technology and technical expertise did improve quite a bit. There has been a revolution in endovascular treatment. We have better catheters, better devices, better wires. We have better filters now, and we have flow reversal. And like I said, I showed you earlier, TCAR is gaining traction as well. So the new trial that we're all waiting for is CREST-2 trial. And the summary of this trial is, it's a two-arm trial. We are comparing asymptomatic patients, okay? This is asymptomatic trial. And we're looking at carotid endarterectomy, so surgery versus best medical treatment, and stenting versus best medical treatment. So this is essentially the first trial since the NASID days that looked at head-to-head comparison between surgical or intervention versus best medical treatment. Started in 2014 and expected to finish next year. So we're all anticipating this trial by the end of next year. In the CREST-2 trial, they appreciated the need for having an expert interventionalist to level the playing field between surgery and carotid stenting. We do not want to repeat the mistakes of a previous trial, particularly EVS in SPACE and the other carotid stenting trial, where they allowed interventionalists who literally just did one carotid stent, and then he started enrolling patients in the trial, and the complication rate was pretty high. So the interventionalists are required to have 30 cases in the last 12 months to be approved to participate in the CREST trial, which is expected to level the playing field between a new procedure, relatively new procedure, compared to a surgery that's been performed since the days of DeBakey in 1953 over the last 70 years, and has been perfected and handed down from one generation to another. So that should be a better study compared to the previous carotid studies. So as of 2021, CMS, or Center for Medicare Services, which is the governing body for payment to physician, reimbursement for physician and hospitals, will reimburse you for carotid stenting only for symptomatic patients who has a certain risk feature, a high risk features. Either a patient is sick, heart disease, severe COPD, or it's a hostile neck, radiated hostile lesion, a very high lesion extending above the mandible, or it's a restenosis after a carotid endarterectomy. So there's certain criteria that will allow them to reimburse for carotid stenting. And as we all know, having a high-risk patient for one procedure does not make it magically a low-risk procedure, low-risk patient for another procedure. But in the infinite wisdom of CMS, that's their criteria they follow so far. And despite the CREST trial that showed equipoise between the two modalities, that has not changed so far. These are the three arms of for surgical management of carotid disease: carotid endarterectomy, TCAR, which is the new kid on the block. This is the hybrid technique. I'm going to go explain it in a little bit. And endovascular, either transfemoral or more recently transradial carotid artery stenting. TCAR does have specific features that allow us to avoid the arch and the booby traps that we can encounter in select patients with terrible arches, avoid cranial nerve injury, and allow us for, and this is the biggest benefit, a flow reversal and take blood away from the brain during this procedure. So there's any debris will go to the vein for neuroprotection. And to qualify for TCAR, you have to have either physiologic or anatomical high risk. The physiologic high risks include older patients, cardiac patients, uncontrolled diabetes, which is kind of vague. So it's very, up to the physician to define what's uncontrolled diabetes, COPD. High risk anatomical criteria, carotid occlusion, previous neck surgery, spine immobility where you cannot rotate the patient's neck, etc. This is a cartoon to kind of explain to you the TCAR procedure. It is performed through a very small incision at the base of the neck, as opposed to a carotid endarterectomy. This is a 2-inch procedure just above the clavicle that allows us to access the carotid artery and isolate it. Once it's isolated, we put a stitch in it for control, and then access it just any vessel access with a needle and a wire, and then put our sheath in it. And this will allow us to have flow reversal. Once we pinch the carotid artery, now the blood is coming back from the brain through this big sheath and goes through a filter that will trap any debris in the filter, and then the blood is given back to the patient into the femoral vein. Once we have flow reversal, the brain is protected because any debris is not going upstream, it's going back into the filter. And we can then proceed with the procedure and deploy our balloon, and it becomes like any other endovascular treatment. But the the main benefit of this procedure is, one, avoiding all the tortuosities and the booby traps in the arch, and the flow reversal is the other main feature of this procedure. And once the stent is deployed, we just pull out and close the hole in the carotid artery. And it's, like I said, it's a small incision. So after I bored you to death with the studies, I'm going to show you some cases to go over the different modalities. I'm going to show you 4 cases. One case is a carotid stent. Another case is a carotid endarterectomy. And then 2 cases that are unique to cerebrovascular neurosurgery, where we deal with acute carotid occlusion. One case is a result of progressive critical carotid stenosis, and the other case, acute thrombus lodging in the internal carotid artery. So the first case is a 62-year-old man who presented with a sudden expressive aphasia and right-sided weakness. So it's a left hemispheric syndrome. And his CTA showed a 80% carotid stenosis on the left side. And this is his CTA. And you can see here, there's a calcified lesion and partially calcified. It's not a ring calcification, and causing about 70% carotid stenosis right there. Sorry, let me just stop it so I can show you this. So the lesion is right here. This is the area of the stenosis on the left side. The MRI, as expected, did show a small punctate DWI diffusion restriction and corresponding with ADC maps. And this is his angiogram. The patient was high risk for carotid endarterectomy, and he was treated with a carotid angiogram. And as you see in the angiogram, the degree of stenosis is confirmed. And more interestingly is when we perform the 3D angiogram to be able to look at the pathology. And this is a modality in the angio suite that will allow us to spin the C-arm around the vessel and can take a 3D picture of the vessel. We see here presence of ulcerated, very nasty looking plaque that is very high risk. This is giving me a lot more chest pain than having just a smooth linear narrowing. When I see these ulcerated plaques, I tend to be a lot more aggressive about treating these lesions, even when they are on the borderline of stenosis, because I know these are high risk, ulcerated, nasty looking plaques that is just a stroke waiting to happen. And I'm going to walk you through the procedure. We do the angiograms under what's called a roadmap. So we do a run, then we select a picture, and that becomes our map for the procedure. And the first step, once we cross the lesion, is to put a distal protection device. This is on the left here. You can see a picture of it. It's like a little umbrella with holes in it that works like a filter that once it's deployed, it will capture any debris that is flowing from the carotid artery toward the brain. And here is the video of the filter being deployed. As you can see right here, you can see this little umbrella is deployed right there in the distal internal carotid artery beyond the stenosis in a straight segment that allow us to deploy this filter safely and capture any debris that might happen, although that's extremely rare. Once the Embo Shield is deployed, and you can see it's center up here, the little umbrella, then the balloon is introduced. And here we have a Viatrac balloon. It's a 5mm diameter, and you can see the balloon slowly being inflated across the lesion and restoring the expected caliber of the vessel. And this is the angioplasty portion of the procedure. Now, we do these procedures for the most part under general anesthesia, although we can do it, and we've done it under local or with a wake patient if the patient is high risk for general anesthesia. We have our neuroanesthesiologist who is dedicated to our neuro program. She's excellent, and we have a very important criteria for blood pressure before the balloon is up, during the balloon is up, after the balloon is up, to kind of minimize any complication that could happen from fluctuation in blood pressure, hyperperfusion, or overperfusing the brain. We also are cautious about inducing bradycardia or asystole during the angioplasty. So our neuroanesthesiologist will have the pacer pads ready. They'll medicate the patient before the, so all these little minor but very important things play a significant role in performing these procedures very quickly. I mean, in this case, I think took about 15 to 20 minutes and very efficiently and in very safe manner. So once the balloon is down, we would move on and put the stent, and here's the stent coming up. And in this case, we used what's called a carotid wall stent. And when we talk about stents, there's different designs, open cell versus a closed cell. And in general, we like closed cell design, and the smaller the holes in the closed cell, the better. And this carotid wall stent has about 1.1 millimeter cell design. And the reason that we like the small design of these cells is that if there's any ulcerated plaque, like this patient I showed you, we're able to trap this, ulcerated plaque against the wall, between the wall and the stent itself. So nothing's gonna break through the stent and go upstream and give you a stroke. This is the stent being deployed. And you can see it's being unsheathed across the lesion from the internal carotid artery down the common. And it's a taper design that allows us to transition from an internal into the common. And once that stent is deployed, we retrieve the Embo Shield. So you can see the retrieval device coming up here and capturing the umbrella. And if there's any debris in this umbrella, is closed and bring everything inside that capturing device, and then everything is withdrawn down and out. And this is what the end results look like after the stent and the angiogram, I'm sorry, the balloon and the angioplasty stenting is completed. You see beautiful, all the ulceration is not seen anymore. It's all hidden behind the stent, and the carotid artery is widely patent. Now, of course, we do perform cranial runs to look at the brain anatomy before and after the stent and make sure there's no vessel dropout, nothing has been gone missing during the procedure. And this is what before and after stenting looks like. Now, these patients are in the hospital for overnight for the stent. They are on aspirin Plavix or Brilinta if they're Plavix non-responder. The next day we get a carotid ultrasound, and on the left picture here you can see the stent widely patent. There's no kinking or narrowing, and on the velocities we have very low velocities, which is good, and there's no stenosis. And the reason we get these ultrasound the next day after the stent is to establish a baseline. And our protocol is to get an ultrasound in the morning after the stent, then at 6 months, and then annually after that to monitor the stent. The second case I'm going to go through it quickly is a symptomatic carotid disease, 90% in a 78-year-old man. And his CTA showed severe, here's the picture right there. So on the left side here, you see a severe stenosis, about 90%. And like I said in the beginning of this talk, this is a CT angiogram. So it does provide great anatomical information that helps the surgeons in making good decisions. One, this is a low lesion, so it's not hiding beyond the mandible. It's not above by C12, so it's a low lesion. It is a focal lesion. It's not a long segment of narrowing that's going to take us with into a long arteriotomy. It's a very focal lesion. It is calcified, so it's better treated with a carotid endarterectomy, get all that crap out rather than trying to break it with a balloon. So all these information are valuable in making a good decision and patient risk stratification. And this is some intraoperative pictures from the carotid endarterectomy. It's as compared to the T-card, it's a little bit longer incision. It's between this hash mark and this hash mark. It's about maybe 6 inches. This is an intraoperative picture, And here we see the anatomy. Number one is the common carotid artery, and you have a vessel loop surrounding it. Number two is the internal, and number three is the external. So this is how the intraoperative anatomy looks like. Here we have the artery clamped. So this big clamp here is on the common, and we have two smaller clamps on the internal and the external. The arteriotomy is opened, and what you see here is being pulled out and dissected from the vessel wall is the carotid plaque. And this is what the carotid plaque looks like after it's been removed. Once the artery has been cleaned out, we either close it primarily, such as in this case. So you can see here the primary closure of the carotid artery is done primarily because the patient's vessel has good caliber and did not require a patch. However, if the patient vessel is small, we can do a little patch to expand the vessel. So it's, this is what a patch closure would look like. This is a different case. That allows us to reduce the risk of restenosis down the road in a patient who has a small vessel, which when we think that we're going to narrow the vessel even more, trying to close it together. So this is one of the lessons that we learned in how to improve carotid endarterectomy is by employing patches more frequently to expand the carotid size. So the case 3 and 4 are unique to cerebrovascular neurosurgeon, where we deal with acute carotid occlusion. I'm going to go through quickly. This is a 57-year-old man presented with a right MCA occlusion and a right carotid occlusion. He's a CT on the right side. You see the carotid artery end up in a stump. And here's the same thing. You don't see any opacification of the carotid artery. And the left side was a string sign as well. Here's a CT angiogram of the head, and you can see the M1 end up in a stump here, and it's missing the distal MCA. And the CTA showing, again, it's a carotid artery on the right side is occluded. CT perfusion, I know Dr. Benning talked about this last week. We have a huge penumbra here on the right hemisphere. You can see all this purple on the cerebral blood flow and preserved blood volume, indicating a huge penumbra. The patient had emergent angiography, and as you see on this angiogram, the right carotid artery ends in a stump. So this is where cerebrovascular neurosurgeon come and play to treat these acute occlusion. And in reality, this has to be treated with endovascular approach. There's no role these days for open surgery anymore. As we see here, there's always, or not always, there's quite often a tandem occlusion in the neck, then another occlusion in the head. And if you just do open surgery, you can't really achieve the goal of the mechanical thrombectomy. And you can see here, this is the angiogram showing a occlusion in the M1 segment. So how do we open these? The balloon angioplasty was performed. The patient had a critical stenosis in this area, and this is angiogram after the balloon was deployed. And you can see we restored flow in the internal carotid artery compared to the previous stump that we had. And then we were able to perform a mechanical thrombectomy and open up the MCA as well. Now, this patient received TPA, so we did not put a stent acutely. This is before and after balloon angioplasty from critical stenosis. And like I said, we did not put a stent because the patient was not on aspirin Plavix. She just received TPA. I cannot load her. So what we do in these cases, we bring the patient back to the ICU, let him recover in the ICU overnight, get an MRI and a CT the next day, as long as there's no hemorrhagic conversion, which typically there's not. We would go ahead and load them in aspirin Plavix and bring them for follow-up angioplasty, follow-up stenting. Here we see the pre-intervention penumbra, and this is what the patient ended up with, a very small stroke on the left side, on the right side. And also we noted that the patient had a left-sided infarct as well, which made that critical stenosis in the left carotid symptomatic as well. And the patient was brought back for a stenting the next morning, and this was done awake to observe the patient neurological function during the stenting, and we performed the left-sided stent as well, and this is what it looks like after the stent is performed. The patient's picture here is a little degraded because she was awake. As you don't see, there's no breathing tube in this patient. I'll move forward here. All running out of time. So you can see the patient end up with a double carotid stenting, left and right. And as per protocol, the next morning ultrasound is patent. The last case I want to show you is a carotid occlusion from a massive thrombus that migrated from the heart. A 60-year-old man presented with aphasia and left hemiplegia. His CTA is very interesting. You can see here the common carotid artery is open, and right at the arrow you can see a filling defect right there, and that's a massive thrombus occluding the internal carotid artery. And the CT angiogram of the head showed a flow limiting thrombus as well at the bifurcation right there. CT perfusion with a penumbra, and this treatment modality is a little different than previous cases. Here we bring our vacuum, and we have special devices to allow us to bring suction thrombectomy catheters into the carotid artery and essentially just vacuum the hell out of the carotid artery and get all these thrombuses out. No TPA since the patient was on anticoagulation. This is the first run, and you can see the catheter right at the origin of the internal carotid artery, and there's no flow distally. After progressive vacuuming of the internal carotid artery, we start having flow, and as we advance our penumbra suction catheters up, we now restored flow to the brain, and literally within 25 minutes, the patient flow was restored, and this is the final results, and we have flow intracranially now as well. And this is a picture of what some of the clot, not all the clot, but this is some of the clots that were able to suck out of the patient's neck and brain, which is quite impressive. And what's more impressive is that this is the stroke, that tiny little punctate thing is all the stroke that the patient ended up having from this massive thrombus that was occluding his carotid artery. So can we do better from an endovascular perspective? Yes, the new trend is radial access. We want to avoid these groins. Our patients tend to get thick in the waist, but no, really don't get too thick around the wrist area. So radial access is becoming very popular. It allows to avoid these disasters of accesses through the aorta, because a lot of times our patients have carotid disease, they have peripheral vascular disease, the iliacs look like crap, and allow us to have immediate ambulation, shorter length of stay, and one of the most feared complications from a groin access is the retroperitoneal hemorrhage. These patients are heparinized up the wazoo. They're on aspirin, Plavix, so any hemorrhage, retroperitoneal hemorrhage, becomes a huge problem, especially if the patient has a stent in the neck. So now what do? You can't really stop the anticoagulation, but they're bleeding, so it's a bad problem to have. And allow us to mobilize the patients very quickly and get them out of the hospital shorter. So after I bored you to death, where do we stand in 2021? So right now we have a robust amount of data to support revascularization for symptomatic carotid disease. Again, that's symptomatic carotid disease. The goal of this treatment is to restore the caliber of the vessel, to improve flow, to stabilize the plaque. And it's not just plumbing. Every patient is different. We need to understand the stroke physiology. There's patients who are high risk for stenting, like this patient that I'm showing you here with this nasty silicone arch. I don't want to put any catheters up this arch. Patients who are high risk for CEA, and there are patients who are high risk for anything. And as one of my mentors used to say, they can't tolerate a haircut. We need to individualize the lesions as well. So this picture here on the right side, heavily calcified lesion, better served with surgery to get that out as opposed to trying to break it with a balloon. This patient in the right lower corner, better served with a TCAR if they have a high risk for surgery to avoid these tortuosity, proximal tortuosity. And patients who, like this patient here on the left side, who have neck radiation or high lesion are better served with a stent. So compared to the first picture, CEA versus stent, now we're not screaming at each other. We are complementing each other. They have very high success rate. Both procedures are fantastic. They have low morbidity and very long-term durability in terms of keeping the vessel open. Like I said in the beginning, I am biased, and I think these lesions are better managed with a surgeon who can who can offer both surgery, stenting, or TCAR, and able to deal with the complications immediately. What is the most severe complication from carotid pathology? Is stroke. And we are able to immediately deal with this complication if it happens immediately, and rather than trying to call somebody else or transfer the patient from one facility to another, which happens sometimes. And by the time the patient gets to us, it's too late, and time is brain. And at the end of the day, it's not CEA versus stent. It's what procedure is better for the patient. How about, I'm running out of time. How about for asymptomatic patients? It's still a moving target. CREST-2 is ongoing. And until then, we have a moving target because, like I said earlier, we are, as surgeons, getting better technically, and our risk and complication rate is dropping. However, also the stroke rate is dropping because of the medical treatment. So what do we do? Meantime, until waiting for CREST trial, we can use other technologies such as 3 Tesla MRIs that allow us to see the plaque, identify the risk factors of the plaque, such as the necrotic core, the presence of intraplaque hemorrhage. And this is very important. The presence of intraplaque hemorrhage was studied extensively, and it was found that the presence of intraplaque hemorrhage carries a risk as high as having a patient with AFib not on anticoagulation. That's pretty significant risk. And also the presence of a thin or ruptured fibrous cap. So these are the 3 major risk features that we can see on MRI that can help us stratify the patients. They also looked at transcranial Dopplers and presence of microemboli to see who patients will be served with surgery rather than treatment. And also, we live in real life, not in CREST-2 life. We have the non-compliant patients who are not going to be taking their medications. Good luck bringing the LDL down to 70. Patients who have stenosis that keep progressing despite best medical management. We have patients that we see, or 1 year they're 50%, the next year they're 60%. They're taking their cholesterol medication, they're taking their blood pressure medication, and despite that, they're gradually, the degree of the stenosis is getting worse. So what do you do with these patients? And patients who do not tolerate best medical management, cannot tolerate the statins from side effects or whatever, or patients who do not have personal trainers and life coaches like the CREST-2 trials. The annual rate of stroke is dropping. And this is the slide on the right side here. It show you the rate of stroke in the asymptomatic control arms of the trials. And you can see it dropped from almost 18% in 1985 down to 2% in 2007. This is ipsilateral stroke in asymptomatic control arms of stroke trials. So that's a significant drop, and that's where the question of what to do with asymptomatic patients remains a moving target. And these contemporary trials, I believe they were when the dinosaur roamed the earth. NASIT was done in 1991. That's when the Terminator 2 came out. ACAS was done in 1995 when Christopher Reeves was paralyzed and gas was $1.15. So that's pretty old news. In conclusion, stenting has reached clinical equipoise with CEA, although CMS has not changed their guidelines yet, but they both have excellent outcomes for symptomatic patient. Randomized controlled trials is needed for asymptomatic patient, and it's ongoing, and we should have results by the end of next year. Individualized management for both patients and lesions is very important, and it's the answer to the problem. It's not one size fits all. And operating experience has been documented extensively, and to the point where in CREST-2 trials are requiring you to have 30 stents a year before you can enroll patients. And between the old guard and the new guard in our program, we have thousands of carotid stents under our belt. And just to put things in perspective, since C. Miller Fisher wrote that paper in 1951, he followed this with this quote: "It's even conceivable that someday a vascular surgeon will find a way to bypass and revascularize the carotid artery." And since C. Miller Fisher wrote this article, we've come with different ways of revascularizing the artery and very high success rate. And we're arguing over a 0.1 difference between this modality and this modality. So we have come a long way since then. And the take-home message after all this talk is, please do not damage my brain fixing my carotid. It is my second favorite organ. And this will end my talk just on time.
Thank you, Dr. Hakma. It was a great talk and necessary talk, because I think, as you mentioned, it was, the carotid artery stenosis treatment is one of the most studied subjects in medicine, what obviously always brings the confusion as well. We do have some questions, and I want to make sure that we cover some of them at least. So I'm just going to jump right into them. So now, one question is, what is recommended timing for endarterectomy or stenting after a small acute cerebral infarct due to carotid disease?
So depends on the size of the stroke. For small strokes that non-disabling, we tend to treat in the acute phase because we know the risk of having a second stroke is high within the first 2 weeks after initial stroke. So if the stroke is not hemispheric, it's not a big wedge, it's just small punctate, that doesn't bother us. We would do the stent or the endart during that same hospital stay.
Okay. Now, do you examine an umbrella for any deposits? And I guess it's for when you do the procedures and a possible specimen.
We do. Well, I mean, every time we put the umbrella, we pull it after we're done and we'll look at it. I'll tell you, I can count in one hand the amount of time that I've seen debris in the umbrella in our institution. However, based on for CMS criteria and reimbursement, you have to use the distal protection device, and in other reports and other institutions, they have a high risk of distal embolization, which made them require the distal protection. However, in our institution, we have I can't tell you the last time I opened the umbrella and found anything inside of it.
Are you aware of any benefit of the PCSK9 binding agents carotid disease? And PCSK9 binding agents, those are monoclonal antibodies to decrease the LDL, and frequently used for the people who cannot tolerate statins.
Right, and that's exactly why, yeah, I mean, that's the new horizon of best medical management. And that's what kept the treatment of asymptomatic disease as a moving target. For symptomatic disease, we have a robust data to treat these lesions. For asymptomatic, I think best medical management may be the answer, except in select patient, but that yet to be seen.
Okay. When reverse blood flow is employed, is there a significant risk of distal embolization due to flow dynamics with abrupt restoration of normal direction of blood flow at the conclusion of the procedure?
I'm sorry, that with a stent you said?
When reverse blood flow is employed, is there a significant risk of distal embolization due to flow dynamics with abrupt restoration of normal direction of blood flow at the conclusion of the procedure?
So we're talking about the TCAR, I'm assuming, with the
Yes.
reverse blood flow. Yeah, there's the TCAR carries the lowest risk of any technique in terms of distal embolization, has the lowest risk because it's flow reversal and there's no the patient is heparinized. It does not carry a lower risk of any technique compared to endart or transfemoral stenting of distal embolization. Okay.
Is pharmacogenomic testing done to determine if patients are clopidogrel non-responders for this? Patients with stent?
Every patient in our institution that get either carotid stent or intracranial stent receive a P2Y12 Plavix response test before, and if they're not responder, they switch to Berlinta typically.
Okay, and the balloon that is placed in the carotid arch using the outflow reverse technique, is it a drug-eluting, and what are the odds that plaque will develop around it, causing issues in the future?
I'm assuming the stent is drug-eluting, the balloons. Yeah. So the stents are not drug-eluting. We don't typically use drug-eluting stents in the carotid artery or in the brain. That's not FDA approved for anything yet, although they're looking at it. So plaque can happen over the stent, but more commonly it's fibrous hyperplasia that happens over the stent. And that's why we monitor the stents down the road with annual carotid ultrasound. And once in a while, you will need to do a follow-up balloon angioplasty over a stent. But like the CREST trial, it is the long-term durability of a stent is equivalent to the long-term durability of a carotid endarterectomy in terms of the restenosis rate. It's pretty low.
All right, and one more question. I know we're a little bit over time, but it's just a minute. When ultrasound shows high-grade stenosis, do you do angiogram or you still recommend MRA or CTA?
So my next step will be a CTA after carotid ultrasound, because that will tell me the location of the lesion, is it amenable to carotid endarterectomy or not. And if it is, then I don't need to subject the patient to angiogram. If I'm going to do a carotid endart, we have two modalities corresponding to the degree of the stenosis. And if the patient has favorable anatomy for endart, then that's what I will do, and I would skip the angiogram. If there's a question or we can't get the answer, then angiogram will be the gold standard.
Dr. Hakma, thank you very much. Just for the questions, I can tell that this talk was really needed. Thank you very much and have a good day.
Thank you.